If I may, I'll start by introducing myself. My name is Dr. Strang, and I'm the Director of the Institute of Advanced Study. And I would like to welcome all of you on behalf not just only the IAS, but also the Wolfson Research Institute and the Durham Forum for Health. We have an annual collaboration between the three bodies, and in accord with our research institute's aim for interdisciplinarity, we have two key things we're trying to do. We're trying to bring an interdisciplinary perspective to each topic here, and we're trying to demonstrate to public audiences the advantages of engaging with a range of disciplinary perspectives. Now, of course, as many of you, probably all of you, will appreciate already, pain management is very complex, and it's very recognised that it needs a multidisciplinary approach, even within the medical field. What we hope will come across this evening is that it benefits even more from a wider disciplinary spectrum of views, which help to locate pain and its management in social, cultural and political context. So we've brought together three panellists, and I'll talk about a little bit in the order of their presentations, so you'll know who's who. We have a medical specialist, Claire Rock, who chairs a Pain in Developing Countries Special Interest Group for the British Pain Society, and she may tell you that 80% of the world's population has inadequate access to pain treatment. So this is very vital work, and it also highlights the importance of thinking about the political and economic dimensions of pain management. We have Susanna Bernhoff from Birkbeck University in London, and her expertise lies in visual culture, and she looks at how pain is represented in historical and contemporary art. And that opens the door to thinking about how images of pain influence how we think about it, experience it, and how we think we should manage it. And we have Dr. Rachel Goodwin-Hill, who's a social anthropologist like myself, and she's at Bristol University. And she has a very in-depth approach to research that unpacks the complexities of how pain is experienced and perceived in diverse cultural settings, and she thinks about how we manage pain as a society. Chairing the panel is Professor Jane McNaughton, whom I'm sure many of you know, Durham University's Professor of the Medical Humanities, and her work does what it says on the tin. It explores the links between medicine and the humanities, including, for example, aesthetic ideas about pain and their representation. So I'm going to hand over to her to chair this session, and we're going to have a series of presentations and so forth. And then I hope that you'll all dive in and participate in the discussion with our panellists. Thanks.
I'm really absolutely delighted to be asked to chair this event. I'm a clinician who also, as Veronica says, works in medical humanities, so I have a keen interest in both the experience of patients and in the importance of approaching this field from an interdisciplinary standpoint. And just thinking a little bit about where I've come across understandings of pain which might be slightly unusual from a kind of medical humanities perspective, one of the most fascinating accounts I've seen of the experience of pain comes from Dickens' Hard Times, the novel Hard Times, when Louisa Gradgrind, if you remember her, the character, asks her mother, "Are you in pain, dear mother?" And Mrs. Gradgrind responds, "I think there is a pain somewhere in the room, but I couldn't positively say that I have got it." And that's a very interesting response, but I think for those of us who have any experience of people who suffer from pain, one can get that sense of how pain pervades the surrounding space that they inhabit, and somehow it can't necessarily be located within the body, but in the space that surrounds you. So it's a very interesting set of questions phenomenologically, I think, in relation to that, which I'm sure our panellists may address. So I'm greatly looking forward to this evening's set of talks and the discussion that will follow. And I'll introduce our speakers in turn. They'll each have around 20 minutes to speak. If there's a little bit of space there, I shall take any burning questions that may seem to arise, but what we might do is try and keep that for the discussion afterwards. Okay, so the first speaker is Dr. Claire Rocks. She is, as Veronica said, chair of the Pain in Developing Countries Special Interest Group at the Pain Society, and she's amazing. She combines life as a consultant anaesthetist in the NHS with work for a PhD at the University of Glasgow in the School of Interdisciplinary Studies. She's also an alumnus of Durham University. She studied medical anthropology here. And as part of her work for her PhD and related to her role in the Pain Society, she spent earlier this year some time in India looking at the problems of pain management there. She combines an amazing range of insights and experience, and we very much look forward to her talk, which is entitled, "Is Pain a Problem to be Fixed? An International Perspective." So thank you very much, Claire.
Thank you very much. Thank you, and thank you for inviting me to come along. It's a real pleasure to be here. And I'm not sure how much we're supposed to declare as declarations of interest, but I also, as part of my role through the British Pain Society, sit on an international committee at the Association of Anaesthetists, and I'm doing some work with the Royal College of Anaesthetists as well, and some of their education overseas. So I'm going to talk about some of the international focus of pain management issues. I'm going to talk first of all about whether or not there's a problem and how it's conceptualised and thought of in certain groups. Then about some of the reasons as to why there are these issues, what initiatives are underway, and finally a little bit about why my research has come about, trying to understand why some of the initiatives have not been quite as successful as everyone would have hoped. So, as we just heard there, the WHO suggests that there are 5 billion people living in the world with low or no access to controlled medicines and have no or insufficient access to treatment for severe pain. This is a briefing note that came out in 2009. And when we talk about controlled medications, we're really talking about drugs like morphine, for those of you who aren't so familiar with the term. So strong, what we call opioid medications that are used for the treatment of lots of types of pain, not necessarily all sorts of pain, but lots of pain, and I'll talk a little bit more about that in a minute. There's been a lot of work from organisations like this, so Human Rights Watch. There's been a lot of work recently talking about access to pain management, and here quite specifically access to palliative care, talking about access to pain treatment as a human right. And I'm not going to talk about the philosophical arguments for and against that, but just to say that that's often how it's being talked about at the moment. A lot of palliative care organisations are talking about access to palliative care as a human right. And this organisation here, IASP, the International Association for the Study of Pain, they wrote a declaration in Montreal in 2010 that access to pain management is a fundamental human right. This organisation is not specifically focused on palliative care. I think it's quite important to say that. They are looking at all sorts of pain management, so whether that be post-operative pain or other sorts of complex long-term pain. But in this document, they also start to explain some of the more specific reasons why they suggest there is a problem with pain management. So, first of all, inadequate access to treatment for acute pain and failure to recognise that chronic pain is a serious chronic health problem. And for those of you who aren't very familiar with our Western biomedicine terminology, in this situation they are specifically meaning acute pain as in short-term pain, so pain that you might get after an operation or after trauma. And in this context, chronic pain means long-term pain, and it's often more complex pain conditions like chronic back pain or even things like phantom limb pain. So they are specifically talking about a Western biomedical classification of pain into different types here. They're saying there's major deficits in the knowledge of healthcare professionals, that most countries have no national policy or inadequate policies, and I'll talk a bit more about that in a minute. And again, that there's severe restrictions on the availability of opioids, so drugs like morphine and other essential medicines, and I'll talk a bit more about that. What they don't mention here, but as you'll see, a lot of these problems are related to developing countries. What they don't mention here is the obvious issue, which of course is about a lack of resources. So resources are often going to be a big issue, whether it's personnel, money, wanting to spend money on other healthcare needs. So resources are obviously a big issue. So these are some documents from the WHO, the World Health Organization, quite specifically related to morphine, which I'm just going to talk about for a bit. So morphine is one of the controlled drugs. It's a drug that is controlled with various legislation and bureaucracy in order to avoid diversion into to misuse for people who it's not prescribed for. And there becomes therefore a balance. The WHO declares morphine to be an essential medicine, a medicine that should be available, but there's also this issue about it being controlled as well. And so there's quite a balance and quite a tension between these two things. thing that happens is every country has to report their usage of these drugs to the International Narcotics Control Board. So the INCB collects a lot of this data, and we can then analyse some of that data. So in 2003, the data to the International Narcotics Control Board came out with some fairly astonishing statistics that 6 developed countries account for nearly 80% of the global morphine use. And if you turn that round as well, 80% of the world's population used just 6%, and essentially these are developing countries. And graphically, the more recent data, so the most recent data we've got is from 2011, and this is difficult, obviously, the countries aren't along the bottom, but each vertical column here represents a country's per capita use of morphine for the year. And the important thing is this global mean that's down here at 6. So there's a few countries that are above it, but the vast majority of countries are way below the global mean there of 6. And this data will come out in every region as well. So this is the Americas, just the Americas. You can see the countries. I know you probably can't read them all, but the point is that above the global mean, Canada and the USA way out here. Argentina is above it, and that's represented in every other region. So Europe, similarly, the Western European countries are over here on the left. I won't show you all of them, but Southeast Asia, it only starts at 1. The global mean is right up here at 6. So in Southeast Asia, they're all out here. If anybody wants to know where these are from, there's a great website I can point anybody to for all the statistics. The Western Pacific, Australia and New Zealand, way above the global mean, which is down here at 6. Everyone else pretty much is way beyond it. So it does become an issue about resources and about under-resourced countries often being the ones that don't have such good access. There's a lot that's been written about this access to opioids. This gentleman at the bottom here, Roger Gopal, he's a palliative care and an anaesthetist working out in Kerala. So there's a huge amount has been written about what the problems are around access to opioids, and it's essentially been categorised into 3 areas. First of all, this issue about policy, so this balance between trying to restrict the use of this drug and preventing it getting into the so-called wrong hands versus making it still available. And in a lot of countries, people are really afraid of being arrested for disobeying the rules and being caught having made a mistake. There's also problems around actual availability of the drugs. One of the problems with morphine, ironically, is that it's incredibly cheap. So there's not really much incentive for a pharmaceutical company to make it available and get over some of this legislation. So in some countries, it's very easy to get hold of the very expensive formulations, and many of you will have heard of a drug called fentanyl, which is a bit like morphine. It's a more expensive formulation. And you can get hold of that for example, in India, where I've worked, where I've travelled. But it's prohibitively expensive. Nobody can afford it, and you can't get hold of morphine, which is made in India, because it's just too cheap. And then there's problems around attitudes and knowledge. So partly because the drugs aren't used, people don't know how to use them, so the professionals don't know how to use them. And there's a lot of stigma associated with the use as well, so patients are afraid to take it. Lots of work underway. I won't comprehensively tell you about everything that's underway from every group. As I've said, Human Rights Watch have had a big campaign, the World Health Organization. The Pain and Policy Studies Group are a group working at the University of Wisconsin, and it's them that's produced all those slides. So they're on their website, and I can give anybody references to them if they wish. Pallium India is the group headed by Raja Gopal I mentioned. They're a group in India that have done a huge amount of work to simplify narcotics regulations in India, and they've just been successful in getting a big change through Parliament there. And there's a group in Uganda who are running a kind of model palliative care organisation, and they actually will constitute their own morphine and have managed to get nurses to prescribe morphine, and have become a real model for how improved access to morphine can be done. Lots of organisations out there, again, I won't go in detail, but just to say there's a lot of palliative care and cancer pain organisations out there. So the Worldwide Palliative Care Alliance, American Cancer Society, International Association for Hospice and Palliative Care, lots of organisations all related to cancer pain or palliative care and cancer pain. Some great resources if anybody is interested. Treat the Pain is a set of short videos. eHospice is a news website, and there's a recently published atlas there from the World Health Organization mapping palliative care across the world. But as I said, much of this work, most of the international stuff, is from the palliative care world. There is some work from IASP, the International Association for the Study of Pain, of which the British Pain Society is a chapter, and also from the World Federation of Society of Anesthesiologists, which again has chapter groups around different countries. And they will focus more broadly on all types of pain rather than just pain related to palliative care. So I just want to speak a little bit about palliative care and what I think are the potential problems with the current situation, and what's interested me to start looking at this in a bit more detail from a research point of view. The WHO definition of palliative care, you can all read here, that it's an approach to improve the quality of life facing problems associated with life-threatening illness. And the key point, I think, to this is the fact that it is related to life-threatening illness. It doesn't include, within that definition of necessarily acute pain conditions, as I mentioned before, so pain of a short-term duration, or chronic pain that is not related to life-threatening illness. So something like chronic back pain is not in itself necessarily life-threatening. And I think the reason that it matters is because within Western medicine, we tend to use different treatments. And certainly the current consensus is that where morphine is a fantastic drug for a lot of palliative care pain and pain at the end of life, and for acute pain, it is often not the most appropriate drug, and indeed has a lot of side effects when we're using it for other sorts of pain. So it is a good drug, but it's not universally the most appropriate drug all the time. And another point is that palliative care on the ground, when I visited parts of India, palliative care isn't always the same as that WHO definition. So sometimes in parts of Kerala, within palliative care, they will be treating all conditions. They will be treating people who have got psychiatric disease, illnesses, people who have got injuries after road traffic accidents and have long-term disabilities, or with back pain or whatever. They are often treating people who would not normally fall under the remit of palliative care. So there's a possible disconnect between what's being discussed at an international level and what's happening on the ground. And I suppose, my hypothesis is that there are some potential problems with that. So the first potential problem is that some people who would benefit from this access to morphine that's being mostly talked about within palliative care are not going to be getting access. So often that would be people post-operatively. And I've seen in hospitals that the situation where you can get access you can have morphine if you've got cancer, but you can't have it if you're having an operation. There's also going to be a lack of focus on alternative treatments that might be more appropriate. So we're only going to go down one line, and that's going to be in practice and education and politically. There could potentially be a sort of complacency or a message sent out that all sorts of pain are being treated and some conditions don't really warrant any further treatment. And finally, as I mentioned before, there's this potential disconnect between what's being talked about in some of the policies and some of the big campaigns and actually what's happening on the ground. So my research, and I'm just going to briefly tell you about it, I won't talk in detail, don't worry, is to try to see why there has been this sort of limited progress really, and there's still huge problems with access to pain management. And I'm using India as a case study and trying to find out a bit more about how pain is practiced there on the ground, and tease out in a bit more detail which patients are treated, what conditions they've got, what sort of health institutions they're going to, what treatments they are receiving, and what clinicians would want to treat in an ideal service. Obviously I have ethics clearance, and I'm going from the University of Glasgow, and I've been recording interviews at this stage with healthcare professionals, so with medical specialists who work in pain management and in palliative care. And I'm also going to be doing some surveys of the ISSP is the Indian Society for the Study of Pain, and then the Indian Association of Palliative Care. So I'm trying to get a sort of view, looking through the lens really of how the clinicians working in India view these problems, and see how that marries up or disconnects with the other views that are being talked about on the international stage. So in conclusion then, the problem, if we want to call it that, and that of course in itself is debatable, but I'm not going to, maybe the other people will want to talk about that, is incredibly complicated, is now increasingly talked about in terms of human rights, which has its own problems. vast and complex. Many local and international organisations are attempting to improve access, often through palliative care. And I would suggest that a better understanding at a sort of detailed local level has the potential to improve access. Thank you.
Björnhoff is our next speaker, and she is Senior Lecturer in Modern and Contemporary Visual Culture at Birkbeck, University of London. And she's worked across medieval to modern periods, including writing a book on sight in the Middle Ages, to a more recent focus on war and visual culture in early 20th century Britain. And I was really thrilled to see Susanna on the, sorry, I'm being dazzled by the lights, I'll move over here. Really thrilled to see Susanna on the list here, because I read her work with great interest a couple of years back when I was setting up an exhibition of these very paintings that we have in front of us. These are pastel portraits by Henry Tonks, who's I'm sure Susanna will tell us more, who was a surgeon and an artist who worked with the pioneer of facial plastic surgery, Howard Gillis, during the First World War. And we had an exhibition here, which the Centre helped to curate and set up a couple of years back in relation to ISD, in fact, which was the recovery of beauty. And so we're now collecting those the essays that came out of that into a book. And so I made huge use of Susanna's work at that time. And I think we might hear a bit more about that work in the talk, which is about to give us, which is called Iconographies of Pain and Stoicism.
I'm really delighted, and I feel very privileged to be here actually, because as I explained to Veronica when she invited me, I feel in some ways ill-equipped to speak about the representation of pain in art. Partly because although I have this interest in the iconography of suffering and a sort of past life as a slightly wayward medievalist, and I currently work partly on medical representations, I don't think of myself as somebody who works on the representation of pain. And actually, this for me was an opportunity to think about why pain is in fact so profoundly absent from many of the images that I've spent many years now, probably too many years, looking at. So I feel that pain in a way is conspicuous by its absence in these sources that I've been working on, sources to do with the First World War predominantly, although I have looked at some contemporary material as well. The book that I've just finished writing is on the cultural history and aesthetics of disfigurement. And it took as its starting point this series of very intimate pastel portraits by Henry Tonks, drawings of facial casualties which were done in 1916 and 1917. Although I work with visual sources, portraits, press photographs, medical records, I'm fundamentally interested in the unrepresentability of certain kinds of injury in the public sphere. In this case, the conventions and anxieties that shaped wartime visual culture and demarcated the public gaze from the professionalised visual practices of both medics, predominantly surgeons, who Tonks collaborated with, and also artists. One of the things that I found is that in Britain, during and after the First World War, facial injury was fairly widely written about, and often in very sort of graphic detail, but almost never shown outside the professional context of clinical medicine. Tonks, as Jane mentioned, worked with a pioneering plastic surgeon called Harold Gillies, and some of the portraits were reproduced in Gillies' textbook, published in 1920, called Plastic Surgery of the Face. But they were never intended for a public audience. And in fact, they weren't seen by the British public until they were rediscovered in the mid-1990s, and some of them were shown at the Venice Biennale. And since then, they've had sort of fairly regular outings, though often within a medical context. And I should say, for anybody who's interested in these, they will be on display for the first time in their entirety as a series at the Hunterian Museum in the autumn. So although images like these record devastating injuries, I'm not sure that we can describe the Tonks portraits as art in any straightforward sense, nor do I think we can say that straightforwardly they are about pain or they represent pain. I'll go back. This paradox, the apparent absence of pain in images of appalling injury, is one of the things that I'd like to explore. First, though, I think it might be helpful if we look at some examples of images that do reference pain. And I should say that one of the things I'm not going to talk about, and this could obviously be huge, I'm not going to talk about contemporary art, though that is an interest. I think very different things are going on there. Pain is referenced not necessarily figuratively, but in a variety of ways. But I'm also not going to talk about photojournalism. And of course, the media obsession with images of suffering has been the subject of passionate debate. Susan Sontag's Regarding the Pain of Others, which I'm sure many of you know, is a good introduction to the arguments, although interestingly, it's a book without any pictures. So what does pain look like when it's the subject of artistic expression or scientific inquiry? Well, Charles Darwin's choice of image to illustrate horror and agony in the expression of the emotions in man and animals is probably an obvious place to start. In the text, he compares human and animal expressions of pain. And I'll just read out this passage. When animals suffer from an agony of pain, they generally writhe about with frightful contortions, and those which habitually use their voices utter piercing cries or groans. Almost every muscle of the body is brought into strong action. With man, the mouth may be closely compressed, or more commonly the lips are retracted, with the teeth clenched or ground together. With man, the eyes stare wildly as in horrified astonishment, hence the slight sort of ambiguity in this category, horror and agony. Or the brows are heavily contracted. Perspiration bathes the body and drops trickle down the face. For his book, Darwin selected photographs from a series published 10 years earlier by the French physiologist Benjamin Armand Duchenne. In these originals, Duchenne's experimental method is visible. He used electrical probes to try and identify the muscles responsible for facial expression. This, in other words, is simulated horror and agony. And in fact, when Darwin showed Duchenne's photographs as an experiment to his friends and family, many of them identified the expression not as pain or agony or even horror, but anger. When he was preparing the illustrations for his book, Darwin instructed the engraver to omit the electrodes and hands of the operator. This has the effect of naturalising the man's expression, of course, but it also neatly avoids the question of whether the experiment was in itself painful or frightening for the subject. And as it happens, both Duchenne and Darwin point out that this particular subject had very little sensation in his face because of a pre-existing medical condition. So they were, at pains. They made it clear that they weren't, in fact, inflicting pain. Interestingly, Darwin had initially thought of illustrating the expression of the emotions with examples of the expression of pain drawn from the history of art. But he says that his search for appropriate images proved fruitless. He couldn't find an artistic equivalent of Duchenne's photographs. The reason, he speculates, is that in works of art, beauty is the chief object, and strongly contracted facial muscles destroy beauty. Pain and anguish are disfiguring, in other words, and art, I might like to think of it as art with a capital A, art in the traditional sense, is concerned with the expression of beauty. Now, we'll return to this assumption in a moment, and it's worth bearing in mind, of course, that it doesn't extend to modern and contemporary art, which often explicitly rejects conventional notions of beauty and visual pleasure. But even if we confine ourselves to the art historical canon of Darwin's day, which encompassed the classical tradition and the Christian iconography of suffering, we don't have to look very far to find examples of what appear to be pain in art. The picture on the left, which is actually a drawing, is from the early 19th century. It's in the collection of the Victoria and Albert Museum, and it's part of their vast collection of studies after the antique, which was a hugely popular genre in the 19th century and part of every art student's training. Found at the baths of Titus in Rome in 1506, the Laocoon group, and there's a detail of the sculpture there on the right, as it became known, was a profound influence on Renaissance artists like Michelangelo. It's also significant for us because it's one of the earliest naturalistic depictions of human emotion. And the date is still a matter of some debate, but it was made by 3 Greek sculptors from Rhodes sometime before 70 CE, which is when Pliny the Elder mentions it in his Natural History. It shows the Trojan priest Laocoon and his sons succumbing to the great sea serpents that the goddess Athena has sent to destroy them during the siege of Troy. Art history students usually encounter the group via the commentaries of 2 18th century scholars, the historian Johann Winckelmann and the philosopher Gotthold Lessing. Both were interested and wrote a lot about the aesthetics of pain. For Winckelmann, the central figure exemplifies the quiet grandeur of classical Greek sculpture. In fact, we now know that the sculpture isn't classical, it's Hellenistic, but I don't think we have to worry too much about that. Laocoon's struggle, says Winckelmann, is dignified and ennobling. It is, in other words, beautiful pain, as far as he's concerned, the embodiment of Stoic philosophy. Gotthold Lessing uses the sculpture rather differently to illustrate the superiority of literature, poetry, over the visual arts. Words don't have to resemble what they signify in order to be understood, he points out, but painting and sculpture are constrained by the necessity of resemblance. And for him, this is a weakness. And of course, again, he's writing about figurative art. We didn't have abstract art in the 18th century. But it's worth pointing out that the same constraints don't apply in the 20th century, or indeed in the 21st. To convey horror, he says, an artist must show us horror. And for Lessing, like Darwin, I think, the graphic depiction of pain or suffering was invariably disfiguring. He uses the term disfiguring, but he also describes it as belittling, verkleinend. So this is interesting. He says that when you find pain, for example, suffering expressed in art, if it's expressed literally, then it's disfiguring and also belittling, unlike the representation of pain or suffering in literature. So depending on whom you side with, the sculpture shows Laocoon's anguish, but in doing so loses its value as art, compromises itself, or it doesn't show Laocoon's pain, but rather portrays the virtues of Stoicism, the transmutation of suffering into beauty, or the sublimation of suffering. Now, religious art is, I'm afraid to say, no less complicated in its attempts to deal with pain. In Christian iconography, the face is a site of transcendence, even or especially when the body bears the marks of suffering. The faces of the martyrs look beyond the corporeal world, beyond pain and death, to eternity. Immortalised by Renaissance painters, the saints, each with his or her own instrument of torture, demonstrated that the face, and therefore the soul, could remain serene, even though teeth were pulled out or eyes were plucked out or the body was burnt or beaten or shot at with arrows. The face of the crucified Christ is allowed to register suffering. Theologically, it's important that he dies a real death, but Christ's face must still be beautiful, and the exceptions to this rule are truly shocking. Hans Holbein's cadaverous entombed Christ is one such exception. It's been the subject of lengthy exegesis, not least of all by Julia Kristeva, but the most famous description is in Dostoevsky's novel The Idiot. And I'll just read this out for you. The picture depicted Christ, who has just been taken from the cross. I believe that painters are usually in the habit of portraying Christ, whether on the cross or taken down from it, as still retaining a shade of extraordinary beauty on his face, a beauty they strive to preserve even in his moments of greatest agony. In the picture, the face is terribly smashed with blows, tumefied, covered with terrible, swollen and blood-stained bruises, the eyes open and squinting. The large open whites of the eyes have a sort of dead and glassy glint. There's usually some ambiguity in these images about whether Christ is actually dead or alive, and obviously this is theologically important as well, because he's supposed to rise again. How could Christ's disciples possibly have believed, confronted with such a sight, that this martyr would rise again? In Illness as Metaphor, Susan Sontag speculated on the lasting impact of this Christian iconography of sacrifice on modern attitudes towards illness and disease. Our very notion of the person, of dignity, depends on the separation of the face from the body, on the possibility that the face may be exempt or exempt itself from what is happening to the body, she argues. Karl Rosenkranz's description of syphilis bears out this observation. In his 1853 treatise on the aesthetics of ugliness, the German philosopher contrasts syphilis with tuberculosis, that most romanticised of 19th century diseases. And I'm quoting him here, the putrescent sores, nauseating eruptions and devastating bone damage of syphilis give rise to the most horrendous deformities. Though equally deadly, tuberculosis, quote, gives the organism a transcendent air that makes it seem ethereal. What a truly luminous sight it is to see a young girl or a young man on their deathbed, victims of tuberculosis, he exclaims. In his own encyclopedic volume on ugliness, Umberto Eco makes the important point that the words we associate with beauty convey a sense of disinterested appreciation, whereas synonyms for ugly often betray a reaction of disgust, if not violent repulsion, horror or fear. As the following terms from Eco's book attest, the moral taint of ugliness is inseparable from its phenomenological effects. So he's not just describing it, but describing its effect on the viewer, the spectator. To be ugly is to be repellent, horrible, horrendous, disgusting, disagreeable, grotesque, abominable, repulsive, odious, indecent, foul, dirty, obscene, repugnant, frightening, abject, monstrous, horrid, horrifying, unpleasant, terrible, terrifying, frightful, nightmarish, revolting, sickening, fetid, fearsome, ignoble, ungainly, displeasing, tiresome, offensive, deformed, and disfigured. So ugliness is not just beauty's other or opposite, it is, to quote Rosenkranz, the hell of beauty. Painters and sculptors, it would seem, had two choices at this point in the 19th and maybe early 20th century. They could represent the disfiguring effects of pain, its capacity to unmake the world, as Hélène Scarry puts it, or they could translate suffering into beauty by representing the overcoming or transcendence of pain. And of course I'm using the past tense in order to just sort of anchor these comments to a historical moment. I don't think they apply sort of universally. Certainly it changes with abstraction in the early 20th century and again with conceptual art in the 1960s. There's one further category of images that we need to think about, and the quickest way to find a representative sample is to type pain into the Welcome Images search tool, which is exactly what I did. And I came up with, I think, 70-something images. This is just a screenshot from my Lightbox, which is actually a fantastic, many of you I'm sure know about this, but it's a fantastic sort of research tool, actually. So, not surprisingly, it's the alleviation rather than the heroic endurance or stoical acceptance of pain that's the subject of many of the images in the Wellcome Library. What is perhaps surprising, or surprised me when I thought about it, is that the portrayal of medical treatment so often borrows from the tradition of caricature, in which ugliness and illness are metaphors for moral decay and social disorder. So really anchored in that tradition that Karl Rosenkranz and Umberto Eco are describing. So we have images of headache, lots of images of toothache and dental extraction, several images of indigestion. This shows the first use of ether as an anaesthetic in 1846, though the painting is much later than that. This one I really like. It's an image of hypochondria, and I'll just read out that caption for you. It reads, "I've got such a pain in my heart, doctor, just here." And the doctor says, "But your heart isn't there." And she says, "Ah, that's the matter then, it's moved." And then, of course, quite a few images from their collection of ephemera, images of advertising. In all these cases, pain is something to be treated, whether pharmacologically, surgically, or perhaps, in the case of the man afflicted with indigestion, through social reform. Sickness here is a social as much as an individual malady. As the historian Lucy Bending argues, Christianity and medicine offered two dominant though conflicting paradigms for understanding pain throughout most of the 1800s. By the close of the century, however, developments in medical science, especially physiology, had begun to dislodge the idea that pain was necessary and instrumental, either as a form of punishment or as a means of atonement. Advances in pharmacology and clinical medicine play a part in this story too, casting doubt on the naturalness and inevitability of pain by approaching it as a bodily phenomenon that could be treated either surgically or chemically. Let's see another example. The process of secularisation and medicalisation that Bending describes is contradicted, however, by the resurgence during the Great War of an unmistakably Christian ideology of suffering. It's also complicated by the persistence of Stoicism as a masculine ideal. The wounded were expected to exhibit fortitude, of course, to make light of their pain, and at the end to die quietly. I've got a motto, were the words to a popular music hall song, "Always merry and bright." We think of injury and convalescence perhaps as passive states. To be a patient is to receive medical treatment, but what comes across in the letters, diaries and memoirs of the war wounded is the performative effort involved. The Liddell archive at Leeds University contains several very detailed first-hand accounts by British soldiers treated for facial injuries. One set of papers comprises the typewritten recollections of John Holtzapfel, along with a scrapbook containing this 1916 photograph from the Tatler of the young captain before his injury, and a newspaper clipping from after the war describing the advances in plastic surgery. Incredibly, Holtzapfel describes the sensation of being shot in the face as not much worse than if I had had a straight left from a middleweight. Feeling a little faint, he's put on a stretcher and carried to the aid post by 4 German prisoners, while a 5th prisoner provides shade with his helmet. A doctor's offer of morphine is declined, and the patient is conveyed to the casualty clearing station. Again offered morphine, loaded onto the ambulance train to Rouen, and from there transported to the coast and finally Southampton. On his way to London by hospital train, he is surprised reading his label to find himself described as gunshot wound, face, severe. At the Great Central Hotel, as the Prince of Wales Hospital was known, Holtzapfel regards his damaged face in the mirror for the first time and can't help laughing, for I had the finest pair of black eyes imaginable. The culture of Stoicism and black humour that comes across in these letters and memoirs goes some way towards explaining the absence of pain in Tonks' portraits, but it's not the only factor. There's a sense here of the surgeon's eye at work, not just because these are drawings of patients before and after surgery, but because Tonks himself trained as a surgeon before becoming an artist. In his memoirs, he admits having often wondered what the figure looks like to anyone who has not this knowledge of anatomy. He wouldn't have been insensitive to a patient's physical pain or psychological distress, but it wasn't his primary concern. There was no assessment of the psychological impact of these injuries, and pain as a discourse doesn't surface in the case notes at all. Surgery is, of course, a supremely material specialism. Nowhere is this more apparent than in the diagrams Tonks produced as a graphic record of Gillies' operations. These capture the surgical gaze and touch in the most economical form possible. The injury is abstracted from its human context, certainly from any suggestion of pain or suffering. To borrow a phrase from the Royal Academy's first professor of anatomy, the obstetrician and surgeon William Hunter, they possess a kind of necessary inhumanity. As drawings, they have more in common, I think, with tailor's patterns than portraits. And for Gillies and Tonks, their purpose was indeed pedagogical, instructive, as well as documentary. Given the speculative nature of this paper, it seems appropriate to finish with a couple of observations rather than any firm conclusions. The first is that images are cultural and epistemological artefacts. They're different, in other words, from the lived experience of pain, whether one's own or another's. This sounds obvious, but its implications, I think, are profound. Painting, sculpture, medical illustration, and even photography never simply represent or record pain or injury as Darwin thought. They make it meaningful, useful even. In the Laocoon, pain is a proving ground. In Christian images of the saints and the Passion, suffering is both instrumental and exemplary. In pharmaceutical advertising, pain is something that can be relieved if you buy the right product. The other thing I've learned from my foray into the iconography of pain is that the question we need to ask is not just the obvious one, how has pain been represented, but also, when is it not shown? When is it perhaps unrepresentable? And if pain is absent from the visual culture of modern medicine, perhaps we need to ask what purpose is served by its absence. Thank you.
And as Rachel's setting up, I'll tell you a little bit about her. She's our final speaker, and maybe a marvellous compliment to what we have had before. Rachel's a Senior Research Fellow and Head of Health Services Research within the Orthopaedic Surgery Research Group at the University of Bristol. She uses her training and background in social anthropology in her research in long-term painful conditions, such as osteoarthritis, painful disabling conditions in later life. Very apposite, I think, in an orthopaedic department. And she also is interested in long-term post-surgical pain. She's already got a strong relationship with us here at Durham as external examiner in the medical anthropology MSc, so it's lovely to welcome you back. And the title of her talk is Research into Pain, Ethnographic and Clinical Perspectives.
It's a great pleasure to be back in Durham. I'm here quite a lot for meetings in the anthropology department, but it's great to be here. There are some similarities between Durham and Bristol, but they're quite small. We're near the sea, but not on the sea. We're a university town, and of course we're on the very opposite sides of the country. Well, I'm going to spend the next 20 minutes talking to you about some of the research that I've been reading about and some of the research that I've been done. Before I do that, I just want to say a little bit about where I'm coming from as an academic and as a researcher. I've got a very conventional background in social anthropology, and these two photographs here show me doing my PhD fieldwork in the Solomon Islands in the 1990s. For those of you that don't know where the Solomons are, and I wouldn't expect many of you to know that, they're in the southwestern Pacific, about 1,000 miles off the coast of Australia. Now, in conventional anthropological fieldwork, we like to spend a lot of time living in a community or a setting and really getting to grips with what people do on a daily basis. So these photographs show me in the setting of Honiara, which is the capital city of the Solomon Islands, where I worked on class, kinship, and ethnicity. The top photograph there shows me doing some work with a traditional healer, and I worked with her to find out how she provided treatment and management for people who came to her seeking cures and help with their ailments. Since finishing my PhD many moons ago now, I decided I really wanted to do some applied research. And so I applied for and secured a job at Bristol within the medical faculty. And this photograph on the right-hand side shows some of the team that I now work with, where I work in the School of Clinical Sciences as one of the few social scientists working within a multidisciplinary team. The team that you can see there includes surgeons, psychologists, statisticians, physiotherapists, occupational therapists, etc., etc. And we're a multidisciplinary team that looks into aspects of pain and pain management, including pain relating to osteoarthritis, which is a condition that affects joints in your body, and pain relating to issues such as cancer, and pain relating to surgery. So a lot of the people that I work with are orthopaedic surgeons, and they conduct knee and hip replacement. But some of the work that I'm moving towards now looks at what happens to people after they have hip or knee replacement, because we now know that about 1 in 5 people who have their knee replaced will encounter long-term pain afterwards. So that's the kind of work that I do now. But what I want to do in the session now is I want to do 4 things. I'd like to briefly introduce 3 ethnographic studies of pain. And I'd like to show what they can offer to our understanding of how people experience and communicate living with pain. I'm then going to talk very briefly about clinical research and what it is. Now, I know many of you in the audience will have a very good grasp of what clinical research is and what it does, but I just thought it's worth spending a couple of minutes on that before moving on to talk about my own research within the multidisciplinary unit where I work, and I'm going to describe to you in a whistle-stop tour some of the qualitative research that I've done over the last few years and work that I've been involved in. I'm then going to very briefly try to bring this all together and try to bring together ethnographic work with some of the more qualitative, clinically applied work that I've been involved in recent years. And this is all going to take about 18 minutes from now. Okay. So I said I wanted to talk about 3 ethnographic studies. And the very first piece of writing that I want to mention is an edited collection. And this is an edited collection of research that was mainly conducted in northeastern America. I want to raise it with you today because it's one of the really seminal collections of anthropological ethnographic research into pain. And when I say ethnographic, what I mean by that is research that involves multiple methods of data collection, particularly including participant observation. And participant observation involves spending time in the community, like I did in the Solomon Islands, speaking with them, engaging, working with them, and finding out what happens in daily life and practice. So this book that I've shown here includes several ethnographic studies and several cases. And these really highlight some of the value of ethnographic research. I shan't describe all of them, but I just particularly wanted to mention a piece of work by one of the editors, Mary Jo Delvecchio Good. And she did some work with older women who live with long-term pain. And what she said was that rather than work, employment for these women, being a cause of stress and a cause of pain, as it's so often understood, work for them provided a haven from their pain. These women living with long-term pain separated their work life from their private life. In their private life, they could express their pain and they could engage with their pain. But their work life enabled them to continue, not as if the pain wasn't there, but to continue with their careers and their professional engagement. The author contrasts this with the experience of younger women. She says that younger women in her study, she doesn't talk about them in detail, but the younger women didn't experience this separation. And for younger women in her study, the work that they did gave them a sense of stress and exacerbated their pain. Studies in this edited collection encourage us to see pain through issues such as work, issues such as morality, and to encourage us to think about the value of people's activities in their lives and the impact of pain on value. Other articles in this edited collection encourage us to think about the potentially destructive nature of pain. But one of the pieces also points out that while other authors, particularly Elena Scarry, have said that pain unmakes the world and destroys language, people with pain are often able to be very vocal about their pain and use a range of vocabulary, as we heard discussed earlier. People really can talk about their pain. So that's the first piece of ethnography I wanted to mention. The second of these is Jean Jackson's work, Camp Pain. That work is featured in the edited collection, but Jean Jackson did an incredible piece of fieldwork in which she spent 12 months working in an inpatient, multidisciplinary pain centre in America. What she said, primarily from her work, was that people who were receiving treatment and pain management in the pain centre felt that their pain was not believed. They felt that their pain was real to them, but was often seen as unreal by the clinicians who were providing treatment. This was a source of tension and conflict. But interestingly, what Jean Jackson also says is that rather than this conflict meaning that pain management didn't work, she felt that this conflict brought to the fore many of the issues that people had with living with pain, and actually this helped the treatment and the management to provide some kind of relief. The third ethnographic study of pain is a piece of work by C. Jason Throop. And Throop worked in Yap, which is in Micronesia, and again I've provided a map to show where that is. It's north of Australia, north of Papua New Guinea. And again, in the tradition of anthropological fieldwork, Throop spent a considerable amount of time living in the community that he was studying. I've chosen this piece of work to describe as I think it's quite a remarkable example of ethnographic research into pain, and shows clearly how pain is understood and related to broader cultural values and idioms. To do his fieldwork, he did participant observation, audio recording, conversations with people, and photographs. Throop argues that pain is both destructive but also seen as something to be endured. He doesn't use the word Stoicism, but he talks about endurance and perseverance. The imperative to endure pain in Yap has moral overtones, he says, and is virtuous, and linked to the value placed on hard work and striving in Yap. In fact, I'm completely oversimplifying what Throop says about pain, but let me just share with you two examples from his work. The first of these is his audio recording and observation of the treatment of a young girl who he calls Tinag. Tinag had fallen from a tree on the way home. I think that's a universal issue. She hadn't done what she was told. She wasn't obedient, according to Throop. Her father then takes her to hospital for initial treatment from biomedicine. He then takes her to the local healer. At the healer, Tinag has massage for her broken arm and resetting. This is an extremely painful process. But Throop summarises the interaction thus, and describes that there is a narrative constructed by Tinag's mother and father about the process that their daughter has to go through. Throop says they think pain happens to her because she wasn't obedient. She was playing on the way home and then fell out of the tree. He says they felt she must be obedient now in order so that the healer can massage her and treat her appropriately. Parents also say that she should persevere during this painful treatment. Then, once she is healed, she'll be able to return to her chores, her community work, and that she will learn from that to have pride in her ability to behave in a more appropriate fashion. She is 10. The second case study is the case study of a woman that Throop calls Fano. And this shows the link between pain and the value of perseverance again, but also hard work to provide for others. Fano is a woman in her 70s. She's had long-term pain in her hands and also in her back. Fano attributed the pain in her hands to her role as an elder in the community, which meant that she'd been involved in mending a stone path in the village. When mending the stone path, stones had fallen on her hands and hurt them. But Fano says that she has had to keep working in the gardens, despite her sore back and despite her hands, because it's crucial that she continues to provide food for others. And she's had to persevere even through the pain to do so. This is described as virtuous woman's work. Again, you see moral overtones here. Tinag was 10 and Fano was 70. So women, girl and a woman, at opposite ends of the life stages, life course. But through these two cases, and Throop does include plenty of other cases in his book, Throop shows us how Yappy's values of endurance, perseverance, hard work and virtue are central to how pain is interpreted. And this, I think, in turn shows the value of some of the detail that long-term ethnographic fieldwork can give us. It can be very hard to get at those kind of things through short-term research. Ethnographic research, then, I think, provides a link between expressions of pain, the experience of pain, and values within cultures and idioms. We can see in the three examples that I've given that there's a value of work for people with pain. We can also see that pain can be destructive and damaging, but that people can talk about pain with plenty of language. We can also see there's a potential for conflict between the clinical, biomedical understanding of pain and patients' understanding of pain. And that particularly focused on psychological interpretations of pain and whether pain was seen as being in the head or in the body. And finally, we can see pain in Yap as understood and therefore expressed in keeping with ideas about the value of endurance and hard work. The three pieces that I've described are not comparative. Each of them describes a particular setting, and they show the link between culture and pain in relatively nuanced ways. But I just want to also share with you a piece that has great credibility in the world of pain research, and this is a piece that was conducted by Mark Zabrowski in the 1950s. I want to share this with you because even when I had a look into this a couple of days ago, it was coming up as a key article that was used in texts for clinical staff as well as for medical sociologists. And so, for instance, in a book called Transcultural Concepts in Nursing Care by someone called Andrews, she says, despite some methodological flaws, this research remains a classic study of cross-cultural pain responses. Now, Zabrowski did a study in North America, and he conducted interviews and observations with 103 patients in a pain centre. And he included in the study Americans of Irish ancestry, Italian ancestry, Jewish ancestry, and a group he calls Old Americans, which is third generation Americans. Now, he concluded from this study that people from Italian and Jewish backgrounds express pain more intensely than people who are from an Old American background. He then said Irish people had more difficulty talking about pain and withdrew socially. He also said that Old Americans were precise in defining their pain and that Italians accepted doctors' versions and decisions about treatment, whereas people from a Jewish background questioned this. So, although Zabrowski is very clear in this piece of work that this doesn't mean that people's thresholds vary, what he's saying here is that people have different interpretations of pain that are related to their, if you like, ethnic or cultural backgrounds. Now, I'd invite you to compare this with a piece of writing from the Solomon Islands that was written in 1927 about pain. So just bear in mind what Zabrowski was saying about pain and people having different interpretations of pain, and I'd invite you to compare it with this. This is a book by Ivers, written in 1927. In some ways, a Melanesian does not seem to feel pain like we ourselves do. But at the same time, he reacts much more quickly than we do to changes in temperature. When at sea, he instinctively dodges the spray, and if caught in the rainstorm, he begins to shiver very quickly, etc. Okay. But whereas a white man in Melanesia suffering from an ulcerated leg or a sore foot can only get about with difficulty, one frequently sees Melanesians in the Solomons who continue doing their ordinary work when they have sores on the legs. Women give birth to children in Melita, in this place, and quite a few days start out again for work in the garden. That's a book from 1927, and I think that's quite difficult to read and hear. I don't think that's appropriate. I think it doesn't show us the nuance of what it is to live with pain. It casts people in opposition. I think that if we're still making use of work such as Zabrowski work, we have to be aware that what it can do is cast people in opposition to one another and provide stereotypes rather than an understanding of the actuality and the nuance of the experience of pain. So I'd say, while we're still using this, we need to be aware of some of the more nuanced work that exists from within ethnography and anthropology. I don't want to dwell on that, it's just something I wanted to flag up and mention. I'd like to move on and talk about some of the clinical research into pain, the world that I'm really involved in now. I'm sure many of you are very well aware about the kind of evidence that influences decisions about healthcare provision and healthcare planning, but just briefly, this is the hierarchy of evidence pyramid that one often sees, which is the way in which evidence, research evidence, is understood as whether it's important and to the extent to which it can influence practice and policy. So at the top of the pyramid, the highest quality evidence we deem to be systematic reviews. And just underneath there we have randomised controlled trials. And down at the bottom here we have case studies, case reports, and editorials or expert opinions. Now the kind of work that I'm involved in qualitative research would fall relatively low down on this pyramid and wouldn't very easily influence care. But what I want to show to you is that the kind of research that we do down here can actually inform work higher up and have a significant influence on decisions about healthcare policy and practice. So I don't want to say that much about the kind of research that takes place in the clinical setting, but very briefly, research can address prevalence and incidence of a condition. It can address the impact, what treatments work best, what treatment is cost effective, what treatment is most acceptable, and how treatment can be organised. A lot of research in pain is conducted by people who are members of organisations like the British Pain Society, and as Claire mentioned earlier, the British Pain Society is a chapter of the International Association for the Study of Pain. These societies are important because they provide a community within which pain research happens, and they encompass basic laboratory research as well as clinical research. These organisations produce guidance for how we might manage pain. They produce guidance and definitions also for how we interpret and understand pain. And at the British Pain Society conference just last week, I was really pleased that someone gave a great presentation that included the International Association for the Study of Pain's definition of pain itself. And what we see in there is that pain is understood not only as a physical experience, but also as an emotional experience. And this echoes what the previous speakers have said about pain actually being understood in a very multidisciplinary way in pain research and also in clinical treatment of pain. IASP also provides useful definitions that enable us to decide whether something is long-term chronic pain or whether something should be defined as acute short-term pain. But I don't want to dwell on what clinical research is, I just wanted to flag that as the background to the kind of research that I do now in the multidisciplinary team in Bristol. And the kind of research that I do now is primarily qualitative, but does feed into larger studies that are higher up that evidence pyramid. So I want to share with you just 4 pieces of work that I've been involved in over the years, and some of these I've led and some of these I've worked with others on and collaborated with them on. Okay. The first of the areas of work that I've been involved in is around living with pain and living within your limits with pain. So we conducted a study as part of a PhD project by somebody called Fiona McKicken, and she spent a good period of time interviewing 31 people, all of whom lived with long-term pain. She spoke with them about what they did on a daily basis. She spoke with them about their use of healthcare and informal forms of care. One of the key findings from her work was that rather than people avoiding activity and daily things because they were afraid of what that activity might do to their pain, they actually avoided activity in order to reduce any potential exacerbation of their pain. This also enabled them to avoid healthcare down the line. Another study that we did looked at the unpredictability of pain. And people living with long-term pain from osteoarthritis told us quite clearly that they not only had ongoing pain that just continued and often got worse, they often had spikes in their pain. So their pain would have unpredictable exacerbations. This was the most distressing aspect of pain for them. We describe that as predictable unpredictability. So that's some of the work that we did into living with pain. We've also done some research into how people express pain. And we asked people to talk about their pain in a series of interviews and focus groups. And then we subjected this language to an analysis that pulled out the most common terms. So a fairly quantitative approach to qualitative data. And we looked at this in terms of gender in particular. And we found that there were differences between the way men and women spoke about pain. We also explored whether people living with long-term arthritis could use colour as a way of talking about pain. Do people like the idea of colour as a way of talking about pain? If so, what colours did they choose for different kinds of pain? And we found some commonalities in this. So people with long-term pain that was maybe slightly dull in character often selected the colour grey to describe this. And we've written that work up. And it might provide another way in which people can think about communicating pain to their clinicians. We've also done some work about how people with pain interact with healthcare. And again, back to hip and knee replacement operations, we wondered how it was that people talked about the possibility of an operation when they were speaking to a physiotherapist or a surgeon. So we audio recorded consultations. And what we found quite clearly in the data was that the surgeons had very different approaches, and some were quite direct and some were more conversational. And what we see here is an example of a physiotherapist talking with a patient, and the patient saying, yes, I'll do whatever you think is right. The key message in that research was that people who were patients adjusted their own communication styles to match those of the patients. But I want to just mention how this research is used and how it feeds up that evidence chain. First of all, some of the research we've done, particularly around unpredictable pain, has been used to develop a questionnaire for use in research and clinical practice. We've developed a questionnaire that can address when people have not only constant pain, but also intermittent pain that's unexpected. And remember, that was the kind of pain that was most distressing. We've also used some of the research to design interventions for pain, multidisciplinary interventions that can be evaluated. And we've also used the research to develop some recommendations around communication. This research that's qualitative in nature can then feed up the evidence chain. And I'll just say briefly that there's a piece of recent work done by Francine Toy, based in Oxford, who's brought together over 77 qualitative studies. And by bringing them together and analysing them in a synthesis, she's got some key findings about struggling with chronic pain. The final one of those on the list is the struggle that people with long-term pain, that's long-term musculoskeletal pain, have to prove the legitimacy of their pain. She's produced a video which shows very clearly that people living with this kind of pain have problems communicating their pain and often feel the need to hide it. And this has clear implications for healthcare provision. But I want to conclude just by mentioning some of the connections. I started out by talking about some of the, I think, seminal and important ethnographies around pain. And some of those ethnographies show that pain destroys, pain is hard to convey and hear, pain has meaning, and pain needs to be understood in context, but that needs to be done in a nuanced way, not a way that couches culture against culture and is stereotypical. I think from the qualitative research that we do, we can also see that pain therapy, pain management has to be desirable, and also we need to ensure equitable access to help and support. I want to conclude by just mentioning something more about the community of pain research. This is a snapshot of a conference. I'm afraid it's an orthopaedic conference. I forgot to take photographs last week at the Pain Society conference. But what we find at these kind of gatherings in this research community that works on pain is a really open approach to understanding pain in all of its forms of expression and understanding all of the issues that arise for people living with either long-term pain or encountering acute short-term pain. So I wanted to finish on that positive note and saying pain research is actually going somewhere quite interesting at the moment. It's suitably multidisciplinary, and patients' voices and the voices of people who are living with pain are being heard. Thank you very much.